discuss a case in hospital management of the hyperglycemia. Next slide. The case is a female, 56 years old. She is a homemaker. She has diabetes from 4 years and level of activity is moderate. Her weight is 75 kilograms. Her BMI is 30.3 kilograms per meter square. That is grade 1 obese. She comes under grade 1 obese. And her fasting blood sugar is 210 milligrams per deciliter, terribly out of control. And glycosylated hemoglobin is 10.2%. It is totally out of control from last 3 months. And she was admitted with fever, malaise, and reduced appetite for 5 days. And her TSH is 1.3, so which is normal. And coming to her BP, blood pressure, 100 by 60 millimeters of mercury. And her creatinine is 2.1 milligrams per deciliter. And her estimated glomerular filtration rate is 26 ml per minute per 1.73 meters square. That is, she comes under stage 4 diabetic kidney disease. So, with fever, her kidney function is badly affected. With fever or without fever, we don't know. This is the AKI. Maybe it is AKI, acute kidney injury with fever. And coming to the liver function test, it is normal. And coming to the saturation of oxygen, SpO2, 89%, which is low. And the diagnosis is COVID pneumonia, where in this case RT-PCR is positive. So we have to, when coming to the medical history, she has hypertension for 3 years and dyslipidemia and hypothyroidism for 6 years. Coming to the drug history, she is on Glimepiride 2 mg per day and metformin 1 gram per day and sitagliptin 100 milligrams per day and telmisartan 40 milligrams and rosuvastatin 10 milligrams and levothyroxine 100 micrograms. And to summarize, a 56 years old lady having poorly controlled type 2 diabetes mellitus, hypertension, dyslipidemia and hypothyroidism, admitted with COVID pneumonia, initiated on dexamethasone 6 milligrams per day. Next slide. So coming to the treatment interventions. So in this case, first we have to stop the oral anti-diabetic drugs and we have to start IV fluids and supportive medications, and instead of OADs we have to start basal bolus regimen, and telmisartan should be stopped as her BP is low. Otherwise telmisartan should be continuous. There is no contraindication in COVID pneumonia, and statin and LT4 is continued. Next slide. And coming to the insulin dose and timing, total daily dose 0.4 unit per kg body weight, and her weight is 75, total dose is 30 units. It is divided 50% basal and 50% bolus, and 15 units degludec at 10 pm and 15 units divided as 5 units fast as part before breakfast and just before lunch and just before dinner. And the day one, the before breakfast, the blood glucose is 180 milligrams per deciliter. The insulin is 7 units, and before at the lunch, the blood glucose is 212 milligrams per deciliter. In the insulin dose is 9 units, escalate to 9, and at dinner, the blood glucose is 250 milligrams, and insulin dose is escalate to 11. And in the after next day, the blood glucose at the time of breakfast is 150, so insulin, same dose of insulin is continued, and at lunch it has come down to 180, so dose is reduced by 2 units, 7 units, and at dinner the blood glucose has come down to 210 milligrams, the insulin dose is reduced to 9. So the correction dose, pre-meal insulin to be adjusted according to the correction dose depending on the pre-meal blood glucose levels, Suppose if the blood glucose is between 100 to 140 milligrams per deciliter, there is no need to correct the dose. You can continue the same dose of insulin. If the blood glucose is between 141 to 180 milligrams, I have to increase by the dose of insulin by 2 units. If it is by between 181 to 220, increase the dose by 4 units. If it is between 221 to 260, increase the insulin dose by 6 units. 261 to 300 milligrams per deciliter, increase the dose by 8 units, and 301 to 350 milligrams per deciliter, you have to increase the insulin dose by 10 units. And if the blood glucose is between 351 to 400 milligrams per deciliter, you have to increase the insulin dose by 12 units. So by the day 3, patient getting better, febrile with adequate oral intake and renal function improved.
Readings on third day, day 3.
And the third day, at the time of breakfast, the blood glucose has come down to 142 and insulin dose is adjusted to 8 units, and at the time of lunch 192 blood glucose and insulin dose is adjusted to 10 units, and at the time of dinner the blood glucose is 174, which is almost normal within the target, and insulin is adjusted to 8 units. So by the day 3, patient getting better, febrile with adequate oral intake, renal function improved from 2.1 to 1.6 creatinine, and eGFR is increased from 26 to 36 ml per minute for 1.73. That is, it has come into the stage of stage 3B DKD. Next slide. So at the time of discharge and follow-up, discharge treatment, dexamethasone reduced from 6 milligrams to 4 milligrams daily, advised to taper it to 2 milligrams after 7 days. So here I will
Just continue. Discussion part will take up. No, don't say that.
Okay.
Later.
Sitagliptin 100 mg, metformin 1.5 grams, and glimepiride 1 mg, insulin degludec 15 units, and 7 days follow-up. Fasting and postprandial blood glucose are 95 milligrams per deciliter fasting, and postprandial 2 hours blood glucose is 146 milligrams per deciliter. Next slide. Thank you.
Thank you.